Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and whether you're here as a nursing student, as a nurse practitioner student, or a nurse here to refresh on pharmacology, I hope you enjoy this series. As we go through this lecture series, we're going to cover nearly everything that you need to know as a nurse studying pharmacology. All of the notes that we're using in this video are available to be downloaded off of our website, and I recommend that you do that, print them, follow along, write your own comments on things that you learn as we go through this lecture. So today we're going to be talking about fluids and electrolytes. And let's begin with a few key concepts. First of all, in fluids, we have two primary groups of fluids that we administer to patients, crystalloids and colloids. There's another term that we're going to discuss shortly that's called isotonic. Isotonic and crystalloid are often used interchangeably, however, they're really not. So let's clarify. Crystalloid is a group of fluids, and then it has several subgroups. Those subgroups include isotonic, hypertonic, and hypotonic. Let's begin with isotonic, which is by far the most used fluid that we have today. The different fluids that we have here are normal saline, D5W, and LR. Let's go through a little bit terminology because you are going to see these different terms in practice. Normal saline is also known as NS, 0.9 or just 0.9, sodium chloride or NaCl. All of those are synonymous terms. Next, we have dextrose 5% in water, which is D5W, or lactated ringers, LR. All of these are isotonic, meaning they're not going to cause a fluid shift between the bloodstream and the cells. The volume that you have in your bloodstream, in your blood, versus the volume that you have in your cells. The differences between each of these is pretty minute. LR has a few different electrolytes in it. Normal saline obviously only has sodium chloride and water, and dextrose 5% in water is just that. It's dextrose 5% with the other 95% being water. So let's move on to indications. The indications for fluid are volume replacement and maintenance fluid. Let's talk about each of those so that you're ready for any test question you may get. What would be an indication for volume replacement? Well, that could be a lot of things. It could be dehydration. It could be diuretic overdose. It could be diabetes insipidus. It could be trauma and blood loss. So there's lots of different reasons why a patient would need volume replacement. On the flip side of that, we also sometimes give a patient simply maintenance fluids. All of us, I'm sure we know, that we have to drink and consume a certain amount of volume of liquid every single day in order to survive. When we have patients in the hospital, if they're in a hospital a long time, if they're on a ventilator, if they're NPO, they're not getting that proper amount of fluid. So we need to administer it to them. How do we do that? We simply give them what's called maintenance fluid, and that's, let's say, a standard order would be 1 to 2 liters every 24 hours. So you take 1 to 2 liters, divide it over 24 hours, and that's going to be your drip rate. And we give this patient so that they're constantly getting fluid. Anytime we are administering a patient fluid, we have to assess the patient's volume status prior to, during, and after intervention. So how would we assess the patient's fluid status prior to administering fluids? Well, there's a few different ways to do that. One of them would be checking their mucous membranes to see if they're dry or moist, checking their skin turgor, checking their blood pressure. All of those could give us clues that the patient is volume depleted. On the other hand, we may have a patient who has too much volume. What would be signs of that? Well, signs of that could be adventitious lung sounds where they have fluid building up in the lungs. Or another sign of that might be where a patient has peripheral edema because there's fluid, extra fluid in the body. So remember to always assess your patient before, during, and after. Now, also keep in mind, especially at the nurse practitioner level, that there are labs that we use to assess volume status. Two of the most specific labs for this would be a urine-specific gravity and a serum Oz. However, you can also use, especially at the NP level, a sodium to tell us, or at least give us a clue about the patient's volume status. Now, since we are talking about sodium here, because sodium goes along with fluids, I want to spend a second and talk about knowing your sodium level. A normal sodium level is 135 to 145. Now, when a patient has that 135 to 145, know that that is relative to their blood volume. So if they have an excessive amount of volume and they still have a normal sodium level, they actually have a low sodium level. Let me explain. If me and the person, imaginary person, standing next to me, both have the same sodium level, we're both at 140. However, I have an appropriate amount of volume. The person next to me has a severely decreased amount of volume. They've been out in the desert for 3 days, haven't had anything to drink, ready to pass out. They have severe dehydration. But we both have the same 140 sodium level. What does that mean? In my case, it would mean that that's appropriate. In their case, that means that they actually have a really high sodium level because it is relative to the volume that they have. In their case, since they have a really low volume, they should have a lower sodium level. Same thing when the sodium level is good relative to hypervolemia. The point is, we have to have the patient's volume status normal or close to it in order to understand whether the patient has a normal sodium level. If the patient has an abnormal volume level, if they are hypervolemic or hypovolemic, we must take that into consideration when looking at their sodium level. Excuse me. The next type of fluids that we're going to go through are hypertonic solutions. Two examples here, 3% sodium chloride or dextrose 5% in sodium chloride. Pay careful attention. Dextrose 5% in sodium chloride is not the same as dextrose 5% in water. Dextrose 5% in sodium chloride, whether it's 0.9 or whether it's half normal saline, both of those are a hypertonic fluid. So what's going to happen with the hypertonic fluid? Because this is definitely not something we would just give grabbing it off the shelf. Well, the doc ordered fluid, let me give them some fluid. Definitely not. This is done specifically when we want to manipulate fluid movement in the body. Let me explain. In order to move fluid from the bloodstream to the cells or vice versa, I can change the osmolality of the blood. So what does that mean? In this case, hypertonic solution has a lot of solute in it. Let's use a simpler word. It has a lot of stuff in it. So if I give this patient a bag of hypertonic solution of 3% saline, it has a lot of stuff in it. And I'm putting a lot of stuff into the bloodstream. So now that I put all that stuff into the bloodstream, and I didn't put a whole lot of water compared to how much stuff I did, the blood now has a ton of stuff in it, but not a ton of water. So what does that mean? That means that in this case, the patient, the body is going to look at the bloodstream and say, oh, wow, you have so much stuff and not a lot of water. Let me give you some water. So we're going to end up moving fluid from the cells into the bloodstream so that it can get balanced out again and not have a ton of stuff in there. So once again, if I give you hypertonic solution, that has a lot of solutes in it. That's going to make the bloodstream hypertonic. That's going to pull fluid from the cells into the bloodstream to balance out so that it won't have a ton of stuff in it. Well, it'll still have a ton of stuff, but now that it got that extra fluid, it's actually still back to a normal ratio. When we're giving hyper or the next one, hypotonic, we're always going to give it through a pump because these fluids can cause these massive shifts. We want to be really careful and judicious with how we give it. We would never want to just eyeball it on a roller clamp. We want to be very specific. Next, we have hypotonic solution. Hypotonic solution, we have a few different examples. We have most common being half normal saline, 0.45, that's half of 0.9. So half normal saline, or we have a third normal saline. We have a quarter normal saline, etc. So all of these fluids are hypotonic. They have very few or very little amount of solute or amount of stuff in it. So in this case, because it has very little stuff in it, but it has a ton of fluid. So I'm putting a ton of fluid and very little stuff into the bloodstream. Now that I put a ton of fluid in there, the bloodstream is going to go, wow, I have so much fluid, but not a ton of stuff. How about I give away some of this fluid to the cells? So this is going to, again, cause a fluid shift. This time it's the opposite. This time I'm going to cause the fluid to shift from the bloodstream into the cells. 2 points I want to make. First of all, an isotonic solution, D5W, becomes hypotonic after the dextrose is metabolized. Now that we've reviewed it, let's see if you understand why. Well, we said it was isotonic. It had a good balance of stuff, solute, and fluid, volume. It had a good balance when I gave it. However, it was a bunch of dextrose and fluid, and it was a good balance. But the dextrose all gets metabolized, and now all that's left is just straight up water. And if it's straight up water without any stuff in it, we know that that's just like hypotonic solution. I don't want to confuse you with this, but you can see this on a test. What happens to D5W after it's metabolized? And the answer would be that the fluid now becomes hypotonic. When we're giving a patient fluid, especially patients in the ICU or on maintenance fluid, we may be giving them sodium mixed with potassium and or bicarbonate. And this is to fix electrolyte issues that we may be keeping an eye on in our patient. Again, be very, very careful every single time you grab a bag of fluid to hang on your patient. Make sure it's the correct fluid. And especially if it's going to be anything other than NS, double, triple check what you're grabbing. So the next big category of fluids after crystalloids are colloids. But before we get to that, since you're still here watching and enjoying this lecture, please go ahead and hit the subscribe button so that you stay up to date with our channel. This channel is a completely free resource for nurses, nursing, nurse practitioners, and nurse practitioner students. And this channel is strictly supported by you subscribing. So go ahead and do that. So let's continue talking about colloids. And some examples of colloids would be albumin, dextran, and there's a few others listed here. So what do we use colloids for? Well, we use it to give volume to a patient. It's a fluid. We use it to give the patient fluid. That much we understand. But why colloids? When would we use it? So colloids, by definition, are a larger molecule. So that has a big advantage. Because it's a larger molecule, it stays in the bloodstream longer. Because anytime I give you fluid, some of that fluid is going to stay in the bloodstream, but some of it just naturally is going to shift out of the bloodstream. Colloids, being a bigger molecule, stay in the bloodstream longer. Okay, well, why do I care? If it's crystalloids, you say it goes out of the bloodstream at some point, no problem, I'll give you more. Well, here's why. Colloids are used a lot in patients where we don't want to just give them more fluid. We want to give them fluid, but only just enough. We're not trying to give them extra fluid. This could be someone in heart failure. This is very commonly used post-cardiac surgery, again, where we're trying to limit their fluids. So a good way to limit their fluids, but still give them some fluid, is to give them a colloid, because that'll give them the right amount that we need, and it'll stay in their bloodstream so that in an hour, 2 or 3, I don't already have to give them more fluids, which I would have to if I use the crystalloid. That's the big advantage. Because these are larger molecules, if you remember from basic chemistry, larger molecules have that attracting force. So not only is it going to stay in the bloodstream longer, it's actually going to pull a little bit of volume into the bloodstream from the cells. So it acts a little bit like hypertonic solution. And what this is called a positive oncotic pressure. If you ever see that term, oncotic pressure is where a larger molecule is pulling something towards it. That's one example of it. The most commonly used colloid is going to be albumin. The big thing to know about albumin, and definitely don't be surprised if you see this on a test, is that albumin is actually a blood product. We get it from when people donate blood. The reason we have to really know that is because not every patient consents to blood product administration. It doesn't have any of the issues of compatibility or anything like that, but it does still have the issues that some people are opposed to blood products. And in that case, you have to alert them that this is a blood product. And if they refuse it, that's certainly their right. Moving on, let's talk about potassium. So potassium, for starters, is available PO, it's available IV, and it's available in our diet. So what's the mechanism of action, quote unquote, of how does the body use potassium? Well, it uses it in a ton of different ways, and I'm not going to go through all of them. It uses it for nerve impulses, it uses it for muscle contractions, it uses it for a whole bunch more. If a patient has a mild case of hypokalemia, we may recommend dietary sources to increase their potassium intake. Obviously, everyone knows bananas is very rich with potassium. Some other examples would be spinach, oranges, avocados, and some other things. What would we give a patient potassium for? Obviously, that would be to treat hypokalemia. What are the signs and symptoms of hypokalemia? Well, for hypokalemia, we know that muscles, we just said, need potassium for muscle contraction. So if I don't have enough, I'm going to have muscle weakness. You would also have anorexia, nausea, vomiting, and some other GI symptoms. On the flip side, If a patient has hyperkalemia, they may develop dysrhythmias, paresthesia. If you don't know what that is, that's numbness and tingling, nausea, and some other symptoms. And these lists are not at all inclusive. However, they do have usually the most commonly asked test questions on what the signs and symptoms are of hyper or hypokalemia. Now, do keep in mind, when we give a patient potassium, potassium is one of the ingredients, depending what state you're looking at, in the lethal injection cocktail that is used to for the death penalty. Potassium is one of the primary ingredients, because if you give a patient a straight up shot of potassium, you will kill them. Note that when you're giving this. This is never given IV push outside of death row. This is only ever given via the IV route when it's in an infusion, when it's diluted, and it's given via a pump. It must always infusion, diluted via a pump. You're never going to give this, just draw up some potassium and inject some potassium unless you're working on death row. When we give this to a patient, it may be painful to the local tissue, let's say the arm where we're administering it. For that reason, we can slow down the infusion, or we can dilute it further, depending what the situation is and what your protocol is. Again, it may be painful when infusing. The solution to that would be to slow down the infusion, would be your first option, or to make sure it's properly diluted, or to ask for a more diluted sample from the pharmacy. We already covered the next 2 points. When you're giving a patient potassium, remember, you need to assess the patient beforehand, during, and after. What does that mean? Well, with potassium, let's go back. We said that high potassium levels can cause dysrhythmias. It can cause paresthesia. We said low can cause muscle weakness. Guess what? You're going to be assessing on your patient during their time of getting this infusion. Exactly. You're going to be assessing them. Check for muscle weakness. Check for nausea. Ask them if they have nausea. Check their dysrhythmias. Every single patient, write this down, every single patient that is getting a potassium infusion must be on an ECG monitor. Okay, you must be monitoring the rhythm, because one of the biggest adverse effects of giving a patient too much potassium is an abnormal ECG rhythm. We definitely want to be all over that to pick up on that right away. And of course, you should always know your patient's potassium level. Most EMRs, you would have to enter that when you scan the medication prior to initiating it. This drug, potassium, is known to be toxic to the local tissue, so please be careful when administering it to make sure you have a patent IV and to continually assess that site. If you do notice that the potassium has infiltrated, immediately stop the IV, reassess your patient, and go from there. Now let's talk if we did give a patient too much potassium. Remember, for too little potassium, what are our options? Diet, supplements, PO supplements, a potassium supplement, or we can give them IV potassium. On the flip side, if they have too much potassium in their body, we can give them insulin and glucose together to bring down their potassium. Let's take a second to make sure you understand the pathophysiology of this. Insulin and glucose counteract each other, correct? When I have a lot of glucose in my bloodstream, the body secretes insulin. The two together walk into the cell, and now we're back to where we started. We have a normal glucose level. However, every time they do that, an insulin and a glucose hold hands, walk into the cell, they also grab a potassium to walk in with them. So when I give you a bunch of insulin and glucose, you're going to have a ton of insulin and glucose walking into the cells from the bloodstream. And if every time they grab a potassium ion with them, all of those potassium ions are going from the blood into the cells. So that will reduce our potassium level in the blood, which every time we're talking about electrolytes, we're always talking about the level in the blood, the serum potassium, serum calcium. Serum means in the blood. That's what we're monitoring. That's what we're talking about. So once again, if a patient has an acute hyperkalemia incidence, and acute usually means that their level is way up, and or that they're having ECG changes or some other symptom showing us that this high potassium level is causing a problem, we're going to treat them with insulin and glucose. And if it is not that serious, if let's say it's a little bit elevated, or if it's a little bit elevated and they have no symptoms, again, I'm not getting into when exactly we would use which, but we do have two medications available. One is called polystyrene sulfonate. The other one's called pteramir. Both of these are PO medications, and both of these can reduce your patient's potassium level. One last thing I want to point out is that calcium is sometimes given for a patient that has a high potassium level to protect the heart. Remember, the heart is extremely sensitive to a high potassium level. We said that a high potassium, straight up dose of potassium can kill a person. If we have a patient that has an acutely high potassium, if they're symptomatic, if we're concerned about the heart, they're having ECG changes, we may give them calcium, and that is to protect the heart in a patient that is hyperkalemic, and I would know that. Now let's move on to calcium. So calcium is available PO and IV. Again, the mechanism of action, what does the body use it for? It uses it for a ton of different things. It uses it for nerve impulses, for muscle contractions, just like potassium. It's also used for bone health. We have more calcium in our body than any other ion because our bones stock it for bone strength. And it's used for a whole bunch of other things. How can we give a patient potassium or calcium? Just like before, we start off with dietary recommendations. So dietary recommendations for calcium would be dairy products, would be fortified juices, things like that. Everyone knows calcium. A lot of juices say, like orange juice will say added calcium. So that would be a dietary recommendation. If we need to step it up a notch, we can do the PO supplements, the over-the-counter or prescription, giving the patient PO calcium. Again, so far, just like potassium. And then we can bump it up even further to give them IV calcium if they're extremely hypocalcemic. So what are the signs and symptoms? It's going to be very focused on muscle and neuro. So signs and symptoms for hypocalcemia are going to be muscle spasms, increased or hyper DTRs, seizures, and again, dysrhythmias and anxiety. On the other hand, if I have hypercalcemia, that can cause confusion, ECG changes, and other GI symptoms, anorexia, nausea, vomiting, etc. Again, I would definitely know this. Keep in mind, pretty much anytime you get an extreme electrolyte imbalance, it can cause ECG changes. Calcium is best known that it deals with muscle contraction, so hypo is going to have that increased muscle spasm, things like that. Hyper can have other symptoms like fatigue, weakness, ECG changes, things like that. The PO version comes bound to various different ingredients. And the important thing I want to point out is not what it's bound to, because it comes in a lot of different options. The important thing to point out is that 45 milligrams of calcium attached to one thing is not equivalent to 45 milligrams of calcium attached to something else. Depending what the calcium is attached to makes a difference on the strength of the calcium. So don't get those confused. If a patient's taking calcium, it's not going to be interchangeable if they switch the agent that it is bound to. Also, any patient that you are educating that they need to supplement or increase their calcium, almost always they should also be taking a vitamin D supplement or at least increasing their dietary intake of vitamin D. When we talk about giving a patient IV calcium, this can be given IV push, and this would be calcium gluconate or calcium chloride. Calcium chloride is 3 times stronger than calcium gluconate. Again, just like the PO, what it's bound to changes the concentration, the strength of what you are giving. And we already mentioned that this is sometimes given to protect the heart in patients that are severely hyperkalemic. Next, we have magnesium, and we don't have as much to talk about with this one. Actually, if you go to the nurse practitioner level, it does get a little bit more complicated because magnesium is relatively briefly discussed in RN level compared to NP level, but we're going to focus on the basics here. Magnesium, if a patient has a low magnesium level, what do? Again, we can increase dietary intakes, we can give them supplements, or we can give it to them in the IV route. The mechanism of action for magnesium is a ton of different things. I'm not even going to get into the whole list of all the different things that magnesium is used for in the body. One thing I will point out, because that's the most likely to come up on your test, is that magnesium is a smooth muscle relaxant. So it causes relaxation of smooth muscles. So your arteries are a smooth muscle. If I give you a smooth muscle relaxant, it's going to relax them, which makes them dilate, which lowers our blood pressure. Your lungs, okay, your diaphragm, your intercostal muscles, those are smooth muscles. If I relax those too much, they stop moving, you stop breathing. Very, very important, especially for testing purposes, to know what are signs and symptoms of too much magnesium. That would be things like a low blood pressure, things like a low respiratory rate, or low chest rise, decreased volume of air that you're moving. Okay, and we're going to talk in a second about monitoring those. But again, This electrolyte is most known, especially for test purposes, as a smooth muscle relaxant. What do we use it for? Obviously, we give a patient magnesium if they have a low magnesium level. Magnesium is also used as a laxative. It is used off labels for a few different things. It's used for acute asthma. It's used for preterm labor. And I want to be clear that when it's used for these things, it is given via an IV infusion. Okay, when magnesium is used for any of these in-hospital settings, it is given via an IV infusion. And I want to point out that anytime you are giving a patient magnesium, you must always monitor their DTRs, their respirations, and you should probably also be monitoring their blood pressure as well. Those would be the most important things to monitor, again, to watch out for those signs of toxicity, especially the respirations, because so many people overlook checking the respiratory effort or the respiratory depth, how much the chest is actually rising, and people just focus on the rate because we could just look at the monitor and tell us the rate. That's insufficient when checking a patient that truly needs their respiratory status monitored. Finally, we have sodium bicarbonate, and sodium bicarbonate is, again, available PO and IV, just like everything that we talked about so far. What is it used for in the body? Its mechanism of action is primarily related to maintaining an acid-base balance. When would we give it to a patient? We give it to them for acidosis. I am definitely not getting into the whole acid-base balance in this lecture, but remember, acidosis means a low pH or a high concentration of hydrogen ions. Low pH or a high concentration of hydrogen ions. And finally, sodium bicarbonate is also used as an antacid. Thank you for watching. Have a great day.